वो करने से बहुत आराम मिलेगा, तुम एक बार करके देख लो।
Guys, can you please mute yourselves?
यही नहीं, हम तो इधर में ही था। ये तो अच्छा ही है, पिच में रहा हुआ था हमारा।
All right, so we are starting our today's presentation. So before we dive into our clinical and technical aspects, let's begin with a thought. Begin with the end in mind and then meticulously plan each and every step to an extent that we need to get there. That's how a treatment plan becomes more successful, more intentional, and ultimately more predictable. Anatomy, optics, and alignment. These aren't just your regular technical and clinical terms, but they are your foundation for more predictable outcome. Whether you're restoring with a direct restorative material or you're going for an indirect restorations, knowing this is going to sharpen your vision and eliminate and elevate your final outcomes. All right. So with that thought, let's begin. First, these are the couple of things that you need to know before you start any of your case. First is going to be your tooth axis, interdental contact points, gingival zeniths, tooth proportion, or as you call it, Golden's proportion, line angles, surface textures, and yes, shade mapping. Incisal edge position.
हाँ उद्या बोल मम्मा से उद्या मम्माची स्विमिंग कॉम्पिटिशन आहे.
Guys, can you please mute yourself? It is honestly very distracting. Papilla position, embrasure spaces, and gingival levels. Finally, most important yet the most underrated step, which is your occlusal analysis. So whenever we are restoring a tooth, all we do is focus on that one particular teeth and give our 100% in restoring that teeth. But we always forget कि ये restoration कितना लंबे समय तक टिकेगा is all dependent on how well your patient's occlusion is. So there are a couple of points that you need to keep in mind. First, if the patient has multiple carious lesions or restorations, and if they have restorations, then you need to check if they are what is the quality of the restoration, molar relation, canine guidance, and incisal guidance. If there is any evidence of parafunction, all these factors can potentially make or break your case. I would like to ask everyone a question. How many times has this happened with you that you have done a beautiful restoration? The shade has matched perfectly. You have given beautiful soft micro textures. सब कुछ एकदम सही है. Yet the patient says, Doctor, कुछ तो अलग है. Something feels off. What do you feel could have been the possible reasons? With that thought, let's understand the aesthetic triad. It comprises of three things: shape, color, and texture. Your patient can barely tell the difference between color unless बहुत major drastic mismatch हुआ है तो ही उनको कलर पॉइंट ऑफ व्यू से आइडिया आता है कि कुछ तो ऑफ है. टेक्सचर not so much, but only thing that they are going to catch immediately is the slightest change in your shape. Primarily, there are three different types of shapes: triangular, square, rounded, and a combination of all of these. So after you have done a restoration, check if guys, please mute yourself. Thank you. So after you have completed a restoration, check if there's a mismatch in the symmetry or a shape related issue. Try and solve that. Now let's go back and reanalyze what exactly is bothering the patient. Many a times they are going to answer with, Doctor, my teeth, it looks wider than the other. और पहले ना मेरे दांत ऐसे नहीं हुआ करते थे, वो थोड़े नैरो दिखते थे, लंबे लंबे थे, ये बहुत ऐसे मोटा हो गया है. So are you going to remove the entire restoration and redo it? No. You are basically going to manipulate with line angles, just your primary surface texture. So if they say, my teeth used to look narrow, now it looks wide, all you got to do is move the line angles from the proximal area onto the surface of the tooth or face of the tooth and make it create an illusion that the tooth now appears narrow. Similarly, if you want to create a wider appearance, simply move the position of your line angles from the face of the tooth into the proximal aspect more. You are basically playing with areas of shadow and reflection, which eventually gives the appearance of narrow or wide or a regular shaped tooth. Alright, moving on to your secondary surface textures, which is the vertical groove going from incisal to the middle third aspect. And your tertiary surface textures, which is perichimatic lines moving from mesial to distal direction. Alright, moving on, since we have covered shape and texture, finally your color. Your color comprises of three things: hue, chroma, and value. Let's understand what all these things mean. Hue is basically identity of the color. Chroma is saturation of that color. Value is lightness or darkness of the color. Very basic. इतना ही याद रखना है when we are selecting your shade. Now, all of us have a small drawer or a box cluttered with different kinds of composite restorations. With different kinds of materials. How are you going to determine that this particular material is the right choice for a particular restoration? Or this kind of material is what you want to reinvest in future? So, let's understand the material science and couple of key points that you need to remember before you invest, starting up with your etchant. Ideal quality of a good enamel etchant is it should be thixotropic in nature. That means your enamel etchant, the moment you dispense it, it should stay in place when it is undisturbed and move or flow when you apply slight amount of pressure. It should not be runny. Traditionally, we had two kinds of etchant in the market. One was what we are using right now, the gel form, and a liquid etchant. Problem with the liquid etchant used to be that it would do its work very nicely, but it would flow and etch places that we were not intended to. So that was not an ideal property. With the gels, we have this thing that it will etch only where you want it to go. Okay, it should be visibly colored, easily rinsable, and it should be of a concentration where it is creating enough microporosities for your resin to penetrate and create micromechanical retention tanks. Non-toxic to soft tissues. and it should maintain its efficacy over a period of time without degradation. All right. Adhesive systems, a big confusion. Wherever I go, everyone is like, क्या चीज उठानी है? इतनी सारी चीजें हैं मार्केट में. Every system that is available in the market has its own purpose, but then it becomes too complicated to add everything in your inventory, which is practically not possible. Let's simplify and break it down. Adhesive systems that are available right now are from 4th generation to 8th generation. 4th generation being classified as your gold standard adhesive system because of its high bond strength to enamel and dentine. However, it is really technique sensitive. Let's simplify it more with based on the etching or their indications. So 4th and 5th generation are your total etch systems where you are supposed to etch the enamel as well as the dentine it's also. All right. 6th, 7th, 8th are your self-etching adhesive systems where they already have incorporated a weak acid into the bonding agent where it is going to etch the dentine by itself. All you need to do is selectively etch the enamel. Just उतना ही याद रखना है. 8th generation bonding agent is your multi-mode bonding agent, which can be used as your total etch, selective etch, or self-etch. Now the big question arises, which system to use and where? It all depends on your substrate. So if you have a tooth where you're dealing with majority of enamel, you can go with a total etch system. If you're dealing with a substrate which is more of dentine, then you need to use self-etch along with selective etching, where you need to just selectively etch the enamel rim and then use a self-etching bonding agent system. All right. Composite resins. It's a vast topic of discussion, but we are going to keep it very simple. So far, we have 4 different types of composites in the market: translucent, enamel, body, and dentine. Your translucent composites are going to be achromatic in nature. They are going to allow the light to pass through them completely. As we can see over here, they are barely masking anything. Such type of composites are excellent when you're building a palatal shell, or you just have to add a thin layer after you have completed the entire restoration. Enamel composites are your tinted chromatic composites. They have a tint of color, but majorly they will be on the translucent aspect. That means they are going to allow the light to pass through them for a significant period of time. With significantly. As you can see over here, it is masking something, but not that much. Then you have something called as dentine composites. Dentine composites will be denoted as AO or AD based on the brand. And enamel, I forgot to mention that, will be denoted with AE. Depending on the manufacturer or the brand or company, they're just going to have different nomenclatures, but that is what they're hinting towards. Yeah, circling back to the dentine. It is chromatic, it is opaque, and it is going to be warmer. This is going to be used as your dentine replacements, and in certain cases where you have to mask a certain level of discoloration, where you don't want that discolored tooth or brown patch or whatever to show through your restoration. It doesn't allow any of the light to pass through them. And finally, your body shades. This has a certain degree of translucency and opacity and chroma. So which is basically best of both the worlds. Because of this property, it is an excellent choice of material when you're going for a mono shade or a single shade restoration. And these are your universal shade composites. And then there is a whole different segment of stains or tints, effects, opalescence, opacers. They are used to create deep fake optics and hyper realistic restorations. So, whenever you have come across a composite restoration, when you can see beautiful amber halo, mamelons, blue tints, this is what we have used in those restorations. So, now let's break down your restorations in 4 stages. First, with your shade matching. Quickest and easiest way to do a shade match is with your composite buttons. All you need to do is analyze the tooth first, understand whether it is more chromatic or it is more warmer in nature. What kind of shades are you supposed to pick? Because each and every composite brand is going to come up with a different shade. A2 from 3M is not going to be similar to A2 from GC. तो आपको वो देखना पड़ेगा कि मेरा दांत येलो टोन में है, व्हाइटिश शेड में आ रहा है, ट्रांसलूसेंसी में जा रहा है. उस हिसाब से यू पिक अप योर मटेरियल्स एंड देन create small composite buttons and keep it ready. Why? I'll tell you soon. So, whenever you are doing a shade matching, everyone, all including myself, what we have done is we place the cheek retractor first, and then एक एक composite निकाल के हम दांत के ऊपर लगाते हैं, and then we cure it maybe like 1 second or 5 seconds. What happens is the moment you retract, your tooth is starting to dehydrate, and it dehydrates completely within the first 3 minutes. So now when you are selecting ये लगाना है वो लगाना है, it has already dehydrated. So you have probably chosen a wrong shade. So keep your buttons ready, retract it, place them simultaneously, and fully cure. When you are placing them, place it in this fashion. Whenever you are matching a dentine shade, place the button onto the cervical third of the tooth. Body shade will be on the middle third. Incisal shade will be on the incisal 1/3 of the tooth. Why? Dentine is most visible in your cervical area because of the thickness. Your enamel is really thin. Incisal shade will be best taken in your incisal area because of the thickness of the enamel, and your dentine is going to be really thin over there. Body shade, as I mentioned, best of both the worlds in the middle surface, middle 1/3. Now, once you have placed it, cured it completely, maybe 20 seconds, 40 seconds based on your curing light, you need to take a picture. The chromatic picture, such as this, the normal picture, is going to denote you which is going to be your dentine shade. So the composite button that merges or blends very well with the tooth is going to be your dentine shade in this image. The composite button that merges very well is going to be your enamel or body shade. So you need to reevaluate with these two pictures. What I like to do is do my shade matching on the first day itself and then reconfirm it on the day of my procedure. So there are certain factors which are the factors which are out of my control is what if the patient has already dehydrated the tooth or who have done something, and by the time they come back it is not in the ideal condition. So I am not wrong when I am taking the shade and reconfirming it on the day of my procedure. Tooth preparation. Imagine this is the kind of tooth that you are supposed to restore. It could be your fractured tooth, or it could be a cavity that you have just cleared off and now you're ready to start your restoration. Look at how jagged or rough these margins are. If you try and directly restore this particular tooth in this fashion, you are bound to make or create a restoration that is extremely obvious and the demarcation line is going to be visible. You need to condition the tooth, make it ready for your composite restoration to adapt. How are you going to do that? With bevels. Starting with your primary bevel, which is going to be given with a red banded burr at a 45-degree angle. This is to remove all the majority roughness, unsupported enamel, and create a smooth transition, which is going to be your first primary bevel. Once you have done that, this is something it's going to look like. Then you take the same burr, keep it at an angle of 65 to 75 degrees, and give a long bevel or a secondary bevel. It needs to start from the DJ and extend up to 1.5 to 2 millimeters onto the facial surface. This is to eliminate any rough margins which have been created because of the primary bevel, loose enamel rods, in order to prevent the demarcation line or the white line that you see on the composite restoration after complete polymerization. So this will be after your secondary bevels. And last, most important and most forgotten step, infinity bevel. So infinity bevel, when every time I speak to someone, they are like कि प्राइमरी दे दो फिर सेकेंडरी आ जाएगा उसके आगे फिर नीचे इन्फिनिटी बेवल आता है. नहीं, इन्फिनिटी बेवल चालू होता है आपके प्राइमरी बेवल से and then it extends up till the secondary bevel and little beyond the secondary bevel. Infinity bevel is basically nothing but you have to take a disc and smoothen the entire bevel area. प्राइमरी से चालू हुआ सेकेंडरी तक गया एंड एक्सटेंड हुआ हल्का सा बियॉन्ड द सेकेंडरी बेवल. So when you are doing this, it has to look so polished after you have given an infinity bevel that you cannot tell where the primary bevel started and where the secondary bevel or your long bevel has ended. No demarcations, no sharp steps, no bumps, nothing, no roughness. Very smooth. Smoother your base, the better your composite is going to adapt. ये कॉन्सेप्ट ही नहीं है कि कॉम्पोजिट के लिए रफ करना पड़ेगा, स्मूथ करना पड़ेगा. रफनेस होगा दिख के आएगा बिकॉज योर कॉम्पोजिट एंड योर टूथ, your natural enamel has different refractive index. So you need to condition the tooth in a way that now it is going to blend and merge and create that camouflage effect that it is a one piece, your monoblock. Okay, so this is how much you are going to layer the composite from this area to little bit more than your infinity bevel. So when you're finishing and polishing, do not remove this bevel. Do not remove this extra composite that you have placed beyond the bevel and onto your natural tooth, unprepared tooth. Many a times it has happened that finishing polishing से पहले सब बराबर है, बहुत अच्छा दिख रहा है. The moment you finish everything, now you're visible. Now the white demarcation line is visible, or you can see that halo की tooth कहाँ पे है, composite कहाँ पे है. Because you have removed this small piece of composite, now the interface is visible. That is why always cover the interface with additional composite. It is not over preparation or ज़्यादा काम कर लिया. That is optimal dentistry. Look at this. So this is your primary bevel. This is after cavity preparation. Class 3 restoration is very difficult to mask, but with the beveling, right amount of beveling, it is possible. This is your primary bevel. This is how much the secondary bevel goes. Certain period of time you need to analyze. अगर लगता है कि cavity बहुत ज़्यादा है, 2 millimeters तक नहीं sufficient होगा, extend it. You can go up to 2.5 to 3 millimeters as well, based on how much you are supposed to restore. That's your primary bevel. Secondary bevel, हमारा infinity bevel यहाँ पे खत्म होता है. And this is after polishing. All smooth transitions, nothing abrupt, no sharp points. Everything is really smooth. Now your composite is going to glide. It is going to seamlessly blend with the tooth surface. So look at this tooth. In this particular case, I was able to create the bevel from primary to secondary to finally an infinity bevel only with discs. बहुत छोटा सा chip है. I don't need to use my burr and just trim everything off. So you need to analyze the substrate and then take a call. What is going to give me the result that I want? Is it a burr? Is it a disc? Do I need to use that burr in aeroter or should I use it in a contra-angle? This is all judgment based call. And then reverse engineer. Imagine the final outcome. Then reverse engineer everything. एक step को break down करो, and then you can go ahead and easily do everything in a predictable fashion. Let's talk about different approaches and different layering techniques. A single modified single shade where you are going to restore majority of the cavity with a body shade and then only the incisal area with your enamel. This is going to be used for your class 4 restorations. A body screen technique is where you first layer a dentine shade, which is going to be your base. Then on the top of it, you're going to add a body shade. This will be primarily used when you're restoring a class 3 cavity. Second, a modified body shade where again you're going to layer the dentine first, then you're going to add a body shade, and finally you're going to add an enamel layer for incisal replacement. Yeah. Then you have something called as controlled body thickness, where you are going to first add a dentine layer, then only leave a 0.5 millimeter of space for your enamel layer. Again, for your class 4 restorations. And finally, your single shade technique, which will be used for your small class 3s and yes, diastema closures. So there are 3 different techniques for a diastema closure. First is your palatal shell creation. Either you can do that with a free hand or by doing a direct mock-up onto the tooth surface, and then you create a palate. Then you take an impression and you have a palatal index. Or you can do a wax up, and with the wax up, now you create a palatal index. What we are going to talk about is injection molding and front wing technique. So BioClear has 2 different lines for anterior restoration. One is the BioClear Black Triangle Kit, where you have a color-coded probe and similarly color-coded matrices in different sizes. You are going to insert this side of the probe onto your black triangle space, and based on the markings and the codings that has been mentioned, you are going to select an appropriate size and color of the matrice for your restoration. You don't need to do any sort of adjustments. All you need to do is pick it up, stabilize, and restore. We are going to talk about BioClear's anterior matrices system for black triangles and diastema closures, which needs adjustments. Okay, so this is our patient. Complaints of sensitivity, little bit of sensitivity over here, chipped enamel incisal area, and food lodgement. But it doesn't look like a clear-cut black triangle closure, right? Let's isolate and check. Can you see how far the papilla has retracted the moment you do a rubber dam isolation? Now imagine restoring this without a rubber dam. It is not possible. or even if you try and restore this, you are either going to create a joint restoration, a overhang, or the gingival clavicular fluid is going to contaminate your bonding. Accidentally, even if you nick the gingiva, the bleeding is also going to contaminate your bonding, which is going to lead to composite failure. So always, always, always use a rubber dam whenever you are restoring composites. Again, beveling. Okay. You have to etch beyond the means of your restoration. ये नहीं कि इतना सा ही restoration था तो why should I etch so much? This is over etching. No, you have to etch beyond the restoration so that you bond beyond the restoration area of restoration, and composite is going to be added not just onto the restoration area but a little bit beyond to create that seamless blends. Since we are etching intact unprepped enamel surface, you have to etch for more than 30 seconds depending on the tooth substrate. It can go up till 60 seconds as well. Keep it and then wash it thoroughly for 20 to 30 seconds with air water spray. Continuously wash karte jao. Once you have washed everything, because all these gels, the thixotropic enamel etching gels, they contain silica. वो ऊपर का ब्लू कलर अगर चला भी गया है तो भी सिलिका पार्टिकल्स निकलने के लिए टाइम लगता है. तो you need to wash it very nicely. Once you have washed it, gently air dry for 5 seconds. And now your tooth is ready for bonding. Since I am restoring the incisal edge first, I have only applied my adhesive on this area, not into the proximal or my diastema closure area. Whenever you are applying the adhesive, you need to actively scrub the adhesive, not like you have just painted and then 3-way syringe se full air blow kar diya. You have to scrub it very nicely for 20 seconds. Once you have done that, gently take your 3-way syringe and blow air until the rippling of the bonding agent stops. This is a very common mistake that including myself, I have done it. 3-way syringe उठाओ, full pressure से air blow कर दो, and अब पता नहीं है कि bonding agent वहां पे है, नहीं है, कितने thickness में बचा है, and then we say, यार छोटे जगह पे ना restoration होती ही नहीं है, छोड़ दो. Instead of just replacing or adding composite over here, I'll give a full composite veneer या फिर subtractive reduce कर देते हैं, enameloplasty करके हो जाएगा. Bonding agent ही हटा दिया air blow करके, कहाँ से टिकेगा? Alright? So gentle air blowing until the rippling has stopped. So now every manufacturer has a different guideline based on the product, because every manufacturer is going to use a different kind of solvent. Some has alcohol, water-based, ethanol-based. So based on the solvent, your air blowing time, your active scrubbing time, your resting period is going to differ. So always read the small pamphlet that you get with the bonding agent. Once you have done this, cure it nicely. I personally like to apply another coat of a bonding adhesive after I've done with one, and then we proceed for final restorations. Freehand palatal shell buildup, since I'm going to only restore this incisal edge with a body shade composite. And adjust it. Don't keep your previous step in a way ki, okay, I have done this much. Now I'm going to do adjustments, corrections in my finishing and polishing stage. No, so each and every step that has to be perfect before you move on to the next one. Remember, correction is going to be difficult than adjustment and reshaping. So whatever is unnecessary, remove it at that period of time. Not with your erotor, but with your contra angle and a disc. And whatever powder has been formed with the composite, just blow air and remove the gross powder. And use a composite modeling agent to clean the tooth surface so that now it's devoid of anything. Moving on. Now I'm going to place my band. In such tight, cramped up spaces, I don't like to etch with the band on, because what happens is whenever you are etching in something which is so tight, so tiny, so cramped up, there is a possibility of your etchant getting entrapped in these regions over here, which might not be washed off, and it will lead to over etching, compromised bonding, and eventually compromised composite restoration. So etch before, then you select your entire assembly and place it. Over here, I have selected this. It is BioClear's anterior matrix system. But look at the way it is fitting. This one looks fine, but the red marking, it looks over contoured, it looks crooked, and I don't like the way my future midline looks. So your band is going to form the future midline. If there are any corrections that you need to do, you need to do it right away rather than doing the correction in the final restoration. बैंड ही ठीक से लगा लो, मतलब फाइनल रेस्टोरेशन में आपके करेक्शन सही नहीं ज्यादा नहीं होंगे. So what I'm going to do is I'm going to remove it and I'm going to trim it. This is untrimmed band and this is the band that I have adjusted. Can you see how much I have trimmed it so that it fits well? Now I'm going to place it again. Looks better, right? I like the midline, I like the fit, I like the contour. Now I'm going to place a wedge and fix my entire assembly. All in place. Now we are ready to bond. Scrub, scrub, scrub. Gentle air blow. Cure. Now since you have already, you're going to cure through the band. Cure each and every surface for 20 to 40 seconds based on your curing unit. So labial, interproximal, palatal, everything needs to be cured very nicely. And you're going to restore with an injectable composite. Mind you, it is an injectable composite. It is not your regular flowable. There is a difference between both the composites. Injectable composite has more filler content. They are more stronger. They have better polishability, and they are more viscous than your regular flowable. Okay, so you need to start from your cervical area and move to the incisal area in one motion. Similarly, inject on the palatal side. रिमूव एनी एक्सेस दैट यू फील. बैंड के अंदर से नहीं, अगर बाहर से कुछ निकल रहा है एंड यू फील यू डोंट, दैट इज गोइंग टू बी ट्रबलसम व्हेन यू आर रिमूविंग द एक्सेस आफ्टर क्योरिंग. रिमूव इट राइट अवे एंड देन यू क्योर. सो दिस इज योर पोस्ट ऑप. कहाँ है कॉम्पोजिट? यू कैन बेयरली सी, देयर इज नो demarcation lines. It has blended so smoothly that you cannot make out where the composite begins and where your tooth ends. Moving on to your front wing technique. A decent sized diastema, maybe 2 to 2.5 millimeters. Imagine restoring this without a rubber dam. Definitely एक overhang आएगा. Your gingiva is going to get nicked because of your matrix. Now look at the amount of papillar retraction we have received just by placement of the dam. So now if I just place my metal matrices in this area without altering anything, what do you think will happen? Any idea? It is going to collapse against the tooth surface. Incisal portion is going to collapse onto the incisal edges. Cervical portion is going to collapse onto the cervical area. You are going to land up with a huge black triangle and a very weirdly shaped embryo space. In order to overcome this, we use something called as front wing technique, where you place two equal size of composite buttons on your incisal edge and simply bring them together to a point that is now going to support your metal matrix like this. Either you can use two buttons or you can layer one composite, join it, and then slice it at the middle with the help of a disc or your interproximal stripping discs. Clean slice. Once you do that, now you place the matrix system and evaluate the midline and support. If you feel it is still falling onto the tooth surface, add more and then reevaluate until you get the kind of embrasure space that you want. Once you have achieved this, now another issue that we face is going to be the collapse of matrix onto the cervical area. Because there is no support over here, it is going to create a big black triangle. To overcome that, we are going to use something called as modified front wing technique with a cervical hip. It is created with the help of a mylar strip adapted to the tooth surface, to the neck of the tooth, and with a drop of flowable composite on either side of the areas to be restored. So once you do that, you are basically creating a support system onto the cervical area where it is now going to support your matrix cervically and incisally as well. If you feel that it is too much, it is wide, it is cramped up, reduce it, it is less, add it. Always make those necessary changes right then and there before you move on to the next step. So now when you place your bands, they are stable, they don't collapse, they are going to create a midline which is aesthetic. They are going to create a space for your papilla to grow, which is appropriate, and a good incisive embrasure. This is how it looks like. Your wings onto the incisal area, the cervical hips created with flowable composites. Now you place the entire assembly and check. Good support, good fit, but I don't like the way I'm getting my papilla space because I feel I might end up with a black triangle. So what I'm going to do, I'm going to remove everything, the metal matrices, and I'm going to add more composite on as my cervical hip and then replace everything and then check. Now I like it. It is not as huge as it was appearing in the previous picture. And now we are ready to restore. Let me just go back. Can you see how much you have already restored by creating wings and cervical hips? All you need to do is restore this particular area and the palatal aspect and you have done. Your 50% restoration is done with this. So I'm going to use a technique called snow plough technique, where I'm going to place a small drop of flowable composite and a layer of packable composite. And then I'm going to gently tap and compress my composite into that cavity. You have to always tap the composite, not compress it the way you use it for GIC. Otherwise, तुम दबाने जाओगे वो composite एक side से बाहर निकल जाएगा, or it is going to get stuck to your instrument. And then we buy different sorts of expensive instruments just because the composite is sticking to it, or it is Teflon coated. That is why you are buying it, because composite दूसरे instrument से चिपकता है. Gentle tap, clean your composite instruments with a basic tissue paper so that whatever resin has been left out because of the composite onto the instrument has been cleaned out. Yeah, coming back to snowplow technique. A drop of composite, flowable composites, and a ball of packable composite. Pack it very nicely. Clean that area labelly. Adapt it very nicely. And whatever you have left onto the palatal aspect, merge it to the palatal side and cure it. Now, once you cure, reassess how much deficiency is there on the palatal aspect, and then you add a layer of flowable, and then you cure, complete the restoration of the palatal side. Then you remove that band of the completed restoration, push the wedge little deeper, and restore the same other tooth in the similar fashion. And that's your post-op. Where's the composite? Where's the tooth? Blends so well. My composite is just a layer. What you see, this portion is your natural tooth, but it is blending so well that I don't even need to give a composite veneer. All I can do is just partial composite restoration and just blend it very nicely, polish it very nicely. And lastly, your finishing and polishing protocols. I'm going to give you a 3-step finishing polishing protocol where your first step is going to be reduction. I don't like to touch my burr to the tooth surface for any sort of reshaping, reduction, or trimming, but if it is necessary, then it has to be done. But try and avoid doing that. Reshaping should be done with a disc, a Soflex disc. Okay? You can do your gross shaping, adjustments of your final shape of the tooth, contours, repositioning of your line angles. This is what you're going to use to reposition the line angles to create the triplanar contour of your tooth. All is going to be done with your discs, medium to fine. Okay. Then for finishing, once you have completed this step, you move on to finishing. This instrument is called Enhance. It's by Dentsply. Enhance cups and cones and wheels. This is a beautiful instrument to remove the burr marks and to create softness and smooth base before you start with polishing. Slow speed, contra angle, maybe medium speed you can use in contra angle without water. With light pressure, it is going to polish and smoothen the composite, but with heavy pressure, it is going and high speed, it is going to selectively reduce your composites. So it is a very good tool if you want to reduce something, but you don't want to use something more harsh like a disc. Okay. And then finally, Eve Dicom twists. Okay, all these things has to go from composite surface to the tooth, not the other way around. If you go from tooth to composite, you are going to remove that small composite that you had left and the demarcation line is going to be visible. Okay, it is always going to be polishing, finishing, everything has to be from tooth surface, sorry, composite to the tooth. Yeah, so polishing, it is going to be used with Eve Dicom. This is your pre-polisher, this is your final polisher. Medium speed, intermittent air and water spray, reverse motion. The moment you put this instrument in a forward motion, you see these leaves, they are going to crack and they are going to break open. Always reverse motion. Take your time when you're using a pre-polisher and this. This is going to give you the glass-like finish which you have seen on social media. Just that's it. You don't need anything else. Let's watch this video. Dr. Fajna, I hope we are on time. We are not running late.
No, doctor.
Okay. So these are a couple of videos that we have recorded for demonstration. First is matrix fitting. So I've already trimmed this matrix according to the cervical embrasure over here. It fits well. And now we are going to, assuming we have already done etching on this tooth surface, now we are going to just bond. Okay, scrub, air dry. and cure. So once you have done this, this is the mylar strip. It's a very common mylar strip. Everyone has this. And adapt it to the neck of this tooth like this over here. And gently place a flowable composite over there. Adapt it again. Then cure it off. Over curing is never going to give you any sort of ill effects, side effects, or whatever. But if you under cure it, that is definitely going to create troubles. So 5 seconds, 10 seconds, nahi. 20 seconds, 40 seconds, if required, 60 seconds करो. जहां पे भी एक्सेस नहीं लग रहा है कि प्रॉपरली नहीं है, करो. ओके, सो यहाँ पे आई हैव restored it, but I feel that I have a lot of excess over there. So I'm going to trim my excess right then and there itself. Until I feel this area is now good enough to go ahead for your next step. Adjust it. नहीं तो यही चीज बाद में बैंड प्लेसमेंट में प्रॉब्लम क्रिएट करती है, वेज प्लेसमेंट में प्रॉब्लम क्रिएट करती है. सारी चीजें होने के बाद में वी आर लाइक अरे नहीं हो रहा है, लेट मी जस्ट रीडू इट और रिपीट इट. Okay, so that much of adjustment we have done. So now we are going to do other side with the packable composite. So one side I have showed you with the flowable, another will be with the packable. Same thing, pack it, adapt it with your mylar strip. Give that contour what you require with the mylar placement and remove excess before you cure. So both the cervical wings are hips are created. One I have adjusted, one I did not feel the necessity to adjust. Here I am creating the front wing. Gently move the composite in the way you want it, in the direction that you want it to go. बटर के जैसे वो मूव होता है if you tap it. The moment you try to compress it, it is going to come out. So just tap it and it is going to go into the direction that you want it to go. You see, I did not remove this portion over here. I think it later got fractured. Or I must have removed it after curing. Similarly, other side. If you're not confident, if you feel that you might land up with a crooked midline, you can use an instrument such as these. I don't remember the name of this, but I'll get back to you if you want it. So you can basically measure measure the difference, and then based on that you can add or trim the composite. Can someone just unmute themselves and tell me if they saw the instrument that I was talking about?
Yes.
Okay, thank you.
It's called veneer calipers.
No, dear, it's a different thing. The veneer caliper is one where you measure the thickness of your crown or your veneer.
What is the name of this instrument?
I'll get back to you because honestly, even I don't remember the name of this instrument now.
Okay, ma'am.
Is it
So now
Evanson's gauze?
sorry,
Evanson's gauze, is it called that? Evanson's gauze.
I'm not sure, doctor. I'll definitely get back to you by the end of this session. Don't worry.
Sure, sure, sure.
Yeah.
Ma'am, which
Yes.
flowable composite you are using?
This is not a flowable composite. This is an injectable composite.
Okay, right, injectable. Which one is this?
So this is from Shofo. Shofo has a really good range of injectable composites, and I think 3M has one. Then GC2. Yeah, GC also has good injectable ranges. So I have removed this band from one side, pushed my wedge deeper. So whenever I want a tighter contact, I'm going to gently push my wedge more deeper into the into the interdental area, and then I'm going to restore the other tooth. If there's any deficiency, ideally don't try and create deficiencies, but then it happened with me. So just add composite over there. Because what happens is when you're working with injectables, if you go to and fro, कि अंदर जा रहे हो, बाहर आ रहे हो, you tend to create voids. Which can, if it's a small void, then it's okay, it's fine. Ideally not, but yeah. But if it's a major void, it will fracture the restoration internally. Look at the amount of excess that we had. Second. Let me just go back and pause it. Yeah. Can you see the amount of excess that we have over here? This is what happens. This is a common, what do I say? This is very common when you are dealing with injectables. You have to deal with a lot of excess. It's easy, but then now trimming the excess is going to be a headache. So if required, use your erotor only to grossly reduce it, not to fine tune it, and then go with fine tuning with your discs. Because वो कितना ट्रिम करते बैठोगे आप डिस्क से. I don't know if I'm pronouncing it the right way. It is called Castroviejo caliper. I'm definitely not pronouncing it the right way. To spell it, it is Castroviejo caliper. Now keep trimming for eternity. Yeah, so I have used my erotor, I have trimmed it. And now I'm going to refine it again.
Dr. Shruti, you pronounced it as Castrovijo.
Okay, thank you.
Yeah, J is silent.
Thank you.
Yeah,
I was 100% sure that I was pronouncing it the wrong way.
yeah, I think it's more like a Hispanic word where J is always silent.
Yes, something like that.
Yeah.
So I have moved on from my discs to enhanced polishers. You see, I'm using it in a high speed, hard pressure mode, and it is reducing so much of my composite. The moment I turn the speed down, it is going to just polish it. And once you are done with this enhance, your overall restoration is going to give out a matte finish. It is not going to give you shiny finish with this. I'm marking my line angles. So whenever you are adjusting the line angles, don't directly use your instrument onto the line angles, otherwise you are going to flatten it out. You have to adjust both distally and mesially of the line angles that you have marked. So now we are basically playing with areas of shadow and reflection. So whenever you are reducing onto the proximal surface, you are making sure keep proximal surface to have the tooth turns inwards, right? It is never flat. So you have to create that inward motion with this, keeping the line angles marked untouched. So line angles are always going to be a raised portion of the tooth. That is why when the light falls, that is what you see. So this is from Optragloss Ivoclar. You can use enhanced points as well. I just had it handy, so I've used it. But enhanced points are going to give you the same effect as this. And always try to polish under rubber dam, and you will see why in next few minutes. Because when you have already put the rubber dam in place, your gingiva is retracted. So you can go subgingivally a bit. Whatever you have to reduce subgingivally, you already have access to those areas. The moment you remove the rubber dam, your gingiva is just going to collapse onto the tooth surface. And now when you're going to take your burr or your instrument subgingivally, it is going to create a lot of bleeding. So wherever possible, always do a gross finishing and polishing, just fine tuning, which is adjustment of your occlusion little bit here and there based on the patient's aesthetic preferences or function. That all you can do it without the rubber dam, but majority has to be done under the rubber dam. I'm just cleaning that area with the wet gauze. I don't like to use cotton, I like to use gauze. If cotton gets entrapped or gets stuck onto the tooth surface, or if you have small roughnesses in your composite or some undercut, the cotton is just going to shove itself in that place. Pre-polisher from Eve Dicom, reverse motion and medium speed from composite to tooth, never the other way around. If anyone has doubt, can they please unmute themselves, because I have minimized everything. I don't know if anyone has raised a question or raised their hand.
Ma'am, is it okay if we can refrigerate the composite and then use a composite warmer?
I don't prefer doing that, but then it depends on the location of your practice. I would prefer you check with your manufacturer or the MR if that's okay. Because then how many times are you going to refrigerate and then heat it up again? You're going to create something like The composition of your composite might get altered with this constant temperature change. So if you have this entire 4 grams or 5 grams of syringe, if you refrigerate the entire syringe, heat the entire syringe and use a tiny blob of it, you're definitely going to change something in the composition.
Okay, ma'am. Thank you, ma'am.
You're welcome. Yeah, so this is what happens. And if this happens in your patient's mouth, you are going to create a big ulcer on the palate. It happens very frequently with me. So I always keep my rubber dam on. And then that was my last polisher. And you are ready to remove the rubber dam. Sorry.
Thank you, Doc, for a wonderful session. One question I would like to ask that what are the precautions post-op precautions patient has to take?
In terms of what, doctor?
In concern of the restoration which we have done for its longevity.
So, couple of things that I would instead of going for the post-op restorations, first adjust the occlusion really well. Can I just quickly finish this? So the references are from a book called Layers. There are 2 books out in the market right now. Legit Bible for your composite restorations. All right. Now let's begin with your Q&A. Let me just my screen. Yeah. Okay. Circling back. Tell me, what were we discussing?
Kindly mention the post-op instructions which we need to give to the patient for the
Yes.
longevity of the patient.
Okay, so firstly, I'm going to adjust my occlusion to a point that patient is not directly biting on the composite. This is something that you need to do before you send the patient off. If the patient is biting on if you have restored a class 4, for instance, you have restored a class 4 restoration, and the moment you ask the patient to bite, if they are clenching or it is constantly hindering with the envelope of function when they protrude, you have to adjust those areas. Then basic instructions are going to be जो भी चीज आप नेचुरल दांत के साथ में नहीं करोगे वो कॉम्पोजिट के साथ में भी नहीं करना. Don't bite anything that is really hard. That can, if it can break your tooth, it will definitely break your composite. Otherwise, I don't give any major post-op instructions, because once you have adjusted the occlusion, the composite is going to stay, provided you have done it under rubber dam and your isolation and bonding protocols are spot on.
Okay, Doc. Thank you so much.
Welcome.
Doc, you used that black triangle matrix or diastema closure matrix from BioClear?
I used an anterior matrix from BioClear. Diastema closure and back triangle matrix are the same thing.
Okay, they are same thing.
Yeah, they are the same thing. So you don't need to make any adjustments. Can everyone just turn on the videos if it's all right? Because I'm talking to a black screen now. Or at least the person who's asking the question. If they're okay, can you please turn on the video? Yeah, so since we were talking about the diastema, the BioClear matrix kit, diastema and black triangle closure is the same thing. It just comes with a color-coded probe, which is specifically for your diastema and black triangles. Otherwise, the anterior matrices from BioClear can be used in any case scenario. You just have to trim the matrix from the cervical region for it to fit better.
Okay, ma'am. And ma'am, like injectable you used, all shades are available there?
Yes, they are.
Okay.
All the shades are available. Injectable comes in universal shades.
Universal shade and A1, A2, A3, AB.
यूनिवर्सल शेड्स एज इन जो बॉडी शेड्स होती है ना इंजेक्टेबल्स
हाँ,
वो
they
सारे
are same.
शेड्स में आते हैं. या
Okay, thank you. Thank you.
वेलकम. Do we have any more questions?
Ma'am, when do we indicate a ceramic veneer? Like what are the indications? When do you go about with composite or ceramic? In which all cases?
First budget, then occlusion. Yeah, budget is a big thing when you're going for ceramic veneers. Then secondly, occlusion. So if the patient has good canine, good molar guidance, you don't have to change much and it is purely for aesthetic purpose, then you can think about going for ceramic veneers. And if you have to do something that is more on the subtractive side, so whatever cases I do with composites are all additive. I don't like to prep my tooth and then give a composite on it because the kind of bond or the kind of contact you are going to get, interproximal contacts that you are going to get with ceramics, they are far more superior than what you get in composites. It becomes very difficult to give those beautiful contacts, contours, and it's a human job. So even with the microscopic void, this is it is a fail, like recipe for disaster. So yeah, additive cases, composite, subtractive cases, look for ceramics.
Thank you, ma'am.
Hello, ma'am.
Ma'am,
For
ma'am,
dentin shade selection, during dentin shade selection, we use chromatic photographs, and for enamel, we use black and white. Then for
Yes.
body shade, which body
बोथ द
shade?
बॉडी शेड जो है वो आपके दोनों फोटोग्राफ्स में इक्वली दिखने वाला है क्योंकि बॉडी जो है उसमें इट हैज इनफ क्रोमा एंड इनफ कलर in any ways the shade that blends very well with the tooth जो आपको हार्डली दिख रहा है is going to be your shade because the only reason of we are going for a black and white because your enamel shade is going to be a value based shade. एनामल में क्रोमा ज्यादा नहीं होता, कलर ज्यादा नहीं होता है, उसमें वैल्यू ज्यादा होती है. इट इज आइदर ब्राइट और वाइट और डार्क और ग्रे. So that is why you have to turn it into black and white and check that.
A4
ma'am, one
means
more question,
body
please.
shade, both photographs are important.
Yes.
Ma'am, can you please go through the slides of shade selection one more, please, fast, if it is possible?
Okay, just let me add there. Yes. This is the slide that you want. So since I was restoring a diastema, whenever you're restoring a diastema, go with a single shade restoration. So all we have chosen, these are different, just a second, yeah. So these are different body shades from different companies. So on this tooth, what we see is your GC body shades. So this is GC A2 and A3. This is Shofu's A2 and A3. So it is just body shade, इसीलिए मैंने middle third पे रखा हुआ है. Had it been enamel, I would have placed it somewhere here, like partially onto the incisal edge and partially outside. Had it been dentine, it would be far up into the middle third portion. Oh, sorry, cervical area, cervical 1/3 portion. And this particular shade blends really well in both the pictures, right? So we chose this, which was, I think, A2 from GC.
Thanks a lot, ma'am. Ma'am, that
Ma'am.
photography part I wanted actually one more
Okay.
time if it is possible.
Photography part as in the picture that we take. So you have to
Yes,
take two.
shade selection, ma'am.
Yeah, so now I've taken these two pictures. All right. So now अभी मैंने मिडिल थर्ड था इसीलिए मैंने रिट्रैक्ट करके नहीं लिया है. Otherwise I would have used my retractors with a contraster and then taken the picture where you can only see the teeth, no lips, no gingiva, nothing. Convert that picture in black and white and see which shade is kind of blending completely with the tooth. So over here, this one is quite visible. This is very visible. This one is partially blending, but then this one looks very seamless. So then this is going to be my final shade. This is my body shade. Similarly, यहाँ पे when I'm trying to match my chroma, all of these are standing out, yet this one looks partially blended. So this is my final shade. And this you need to do it twice. So once on the day of your first appointment, secondly on the day of your procedure. So on the second day, all I'm going to do is take this shade of composite, place it onto the tooth surface, middle third area, cure it, completely cure it, and then take the image again, just to reconfirm that the shade that I have selected is the right one. I hope that clears your doubt.
Yes, ma'am. Very clear. Yes, ma'am. Thank you so much.
Ma'am, what are the commonly used shades in Indian population? Like
A2,
frequently used.
A3, A2, A3. These are the commonly and frequently used shades in Indian population. But Shofus A3 is going to be different from GC, from Tetric and Ceram, from 3M, from Tokoyama. So it all depends on chroma based composites. So you need to have different kinds of composites in your inventory to get that effect. एक ही kit अगर आप purchase करोगे तो आपके काफी patients में use तो हो जाएगी वो, लेकिन there is going to come one bugger who will be like, no, doesn't match. Now you need to add something else. So have different shades of composites.
Ma'am, which was the metal matrice or the steel matrice that you used in the diastema?
It is called a shovel matrix and it is from Tor VN. So this is the kit for the shovel matrix. Is it visible? Is it visible now?
Yeah, visible, ma'am.
So you get different shapes of matrices in this. This is the uneven one. Yeah. So you get different shapes. This looks like your normal sectional matrices, but it comes with a handle. This is the shovel small. This is a big shovel, and then this you have a replica of Unica or something that is going to create a composite veneer. You have assorted here. The best part about that matrix is you can pinch the ends with your own hand and then you can place it. With the small sectional matrices, sometimes it becomes a little tricky to place it, or if it falls, then to stabilize. These are better. Name, it's called shovel matrix from Tor VM. This one.
Ma'am, can I place ortho bond in between if midline diastema is space is 2.5 or more? Ortho bond, which ortho bond we can place orthodontic where?
Ortho bond is that a different orthodontic bonding agent?
Yeah. Ortho bond with wire, splinting wire or any type of wire we can place in between
Yeah,
midline spaces.
once you have restored it, you can place whatever ortho bond if you want to just bond those two incisors with the wire.
Which
That's
number wire 14? We can start from 14 or we can dial for 17 or 19.
Dear, are you asking me about placing a bonded retainer palatally, or is this a different different question?
In wire, in a midline closer for wiring, orthodontic wire.
Anything. I usually prefer my orthodontist to do it.
Okay.
Doc,
Yeah.
which modeling resin you use?
It is from Bisco.
Bisco.
Yeah, Bisco modeling resin.
Thank you.
Ma'am, OA2 from Tokoyama is a dentine shade or universal shade? I'm little confused.
Dentine. Anything that says O or D, as in OA2, OD2, ये सब डेंटिन में आता है. अगर E बोल रहे हैं वहां पे, then it is going to be your enamel shade. कुछ भी नहीं है, then it is your regular universal body shades. Certain brands are going to say it AB2 as well. So that could be your body shade, but then you need to check with the kit. What exactly are they providing in it? Any more questions? Or should we call it a day?
It's a great lecture. I want to
Thank
ask
you.
one thing. One of my patient after midline diastema closure had bleeding gums when she reached home. So
Okay.
it stained the entire tooth composite line. So
Okay.
what will be the best possible solution for this, like when she
So
comes back?
after the restoration, I'm trying to understand. So you did the restoration. She had bleeding gums, and then the entire composite got stained. What was your? Did you use a rubber dam first?
No,
Was
ma'am.
okay.
Rubber
So
dam,
there
mostly in India, like mostly we don't use rubber dam.
you have to, dear, whenever you're doing composite, it is not that expensive. रबर डैम का मेजोरिटी किट जो होता है वो आपका इन्वेस्टमेंट है. जो बचता है जो डिस्पोजेबल है वो आपका सिर्फ शीट्स है विच इज barely 18 to 30 rupees per sheet. So we are charging a decent amount for a composite. Learn to do rubber dam. Okay. So either there must have been some sort of overhang, which is why, or you must have nicked the gingiva. And now tell me about your polishing protocols. Did you go with the sequence that we talked about, or did you have a different sequence, or was it just polished with a yellow band burr in erotor? What was it?
So I used the yellow band polishing.
Okay.
The burrs. Then I used the polishing disc and cups.
Polishing disc
Cups
and
from-
cups. Which one?
Yes.
Which company?
Shofu.
Okay. Then either it was not polished really well, because of which your superficial composite has been stained. Because what happens whenever we are using the sequence goes, you need to polish it well. So the polishing discs and everything from Shofu could have been the finishing step, which is why you are left with a matte surface. So जो भी matte surface होगा उसके ऊपर वो चिपकेगा. तो superficial layer आप remove करें, and you need something as rubber polishers to give that gloss. So once you have polished with the rubber polishers, कुछ नहीं चिपकता. It doesn't get stained. And even if it does, you can just repolish it.
Okay, so which band rubber polisher should I use, ma'am?
So the one that I showed you, Eve Dicom, they are really great. It's good, economical, and lasts a really long period of time. This one, the one that I showed in the presentation, it comes with this three polishers, three polishers, and reverse motion, medium speed, intermittent water spray.
Okay, thank you, ma'am.
Welcome.
Ma'am, are we going to get recordings of this lecture?
Dr. Fajna, that's for you.
To all participants, information there is.
Ma'am, can you repeat the name of caliper or?
Who was that who pronounced it the right way? Someone pronounced it the right way. I've just added it to the chat box. Yeah. That's
Ma'am,
the
can
one.
I, ma'am, after after diastema closure, can I put the veneers? Which type of veneers you can suggest, or how must I use BART or complete type?
But why do you need to place a veneer after diastema closure? You can bond to the composite if that is what you are asking. But अभी close करने के बाद में वो आपको slice करना पड़ेगा क्योंकि your veneer margin cannot be on composites. It has to be on enamel.
Okay, because some patients are asking few days back.
If you want to do a veneer, you can do it, but then your veneer margin should be on sound enamel. not on your composite. So you'll have to slice open the composite restoration and then prep it.
Okay, okay. For ma'am, for extra support, any type of FED we can place?
For extra, this is a
Support.
complete different topic of discussion. I don't think we will have enough time to have this conversation today.
Okay, 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 ma'am. Thank you, ma'am.
Yeah.
Ma'am, will we get the recording of the session?
The recordings will be found in IETP YouTube channel. For those who require it, can watch it in IETP YouTube channel.
Could you share us the link on the WhatsApp group or on in the chat box?
Sure. I'll be sharing the link in the WhatsApp group.
Thank you.
So I have seen someone messaging how to reverse speed in micromotor. You have a button on the micromotor. So if it says your chair, you will have an option. Just check with the chair functions. Or if you're using an external micromotor, there is something called F and R. So F would be your forward, R would be your reverse motion. You can do that.
Ma'am, if in patient in trauma from occlusal, like in fractures, like Alice class 3, and after that, after patient with vitality loss, and we can do RCT, and after that we can make composite and diastema closure, or we can directly go for FPD.
You can definitely go for composite restoration. Why not? But then
It will lasting because it if chewing or it's may cause pain or not.
see, it
Or
depends
sensitivity.
on the patient's usage now. So in certain cases, if it's a young child or you're dealing with someone who has severe crowding and yet to go for ortho, you don't have the option of giving a permanent restoration. You still have to do the composite restoration. If you are concerned about that, you can give certain instructions that khane ka that it is your just something to show. It is not for your function. So you need to be very careful with that. And you can give a hard splint at night. The Essex that you provide after ortho, that you need to provide the patient for nighttime protection to protect it from parafunctional habits. And basic instructions like not to bite directly from the front teeth or the tooth that has been restored. No first bite like apple, guava, sugarcane, anything like that.
How much time?
Forever until you go for a permanent restoration. So it depends on how much tooth has been lost and how much what is the size of the restoration that you're doing.
Okay, ma'am. Thank you.
So what happens in such cases, as you were talking about Ellie's class 3 fractures, if the patient is good, educated and compliant with all your instructions, the composite restoration do last really well. But then if they don't understand why are we doing this particular, it can be a long-term interim restoration since they are not at a stage that we can give them something more permanent. So they have to maintain it until you reach that stage for a permanent restoration. They keep coming back with fracturing the restoration or now something else. So you have to give those series of instructions and a hard night guard.
For adult patient also, night guard we put.
Yes. There have been
Okay.
couple of patients of mine where we have restored from I think we have restored 8 millimeters of the tooth structure. That is basically middle third to incisal third because she had severe crowding and she had fractured the tooth. And you cannot give a crown to that kind of patient. So you will have to go for ortho first. In the meantime, you cannot keep it open. आपको कुछ तो restoration देना पड़ेगा ना.
And night guard wearing time for adult patient?
Completely. Have food, wear the night guard, remove it the next day. If possible, only remove it if the patient is a known bruxer or grinder or clencher. Only remove it while eating or drinking. That's it.
And normal brushing habit.
If they are a known patient, if they know that they do some sort of parafunction, अगर वो bruxing कर रहे हैं, clenching कर रहे हैं, grinding चल रही है उनकी, तो फिर उनको सिर्फ खाना खाते टाइम पे ही वो रिटेनर निकालना है. अगर नहीं करते हैं, वैसा डे टाइम कुछ नहीं है, तो फिर रात को ओवरनाइट इज इनफ.
Okay, ma'am. Okay, ma'am. Thank you so much.
I hope all your doubts have been cleared.
Thank you, Dr. Saab. Thank you for such a nice lecture. It was wonderful. Can we get that PDF of book layers?
Unfortunately, I don't have the PDF of the book, but you can try looking for online. You will definitely get it.
Right, it's not available on my.
Ma'am, can you share your contact details like Insta, email, or contact number for future?
Second,
reference?
I will just share the screen. Yeah. So, for everyone who's asking for which books is this, it's layers. मिलना चाहिए ऑनलाइन, कहीं ना कहीं से तो डेफिनेटली मिल जाएगा. And yeah, so this is my Insta handle. If anyone would like to get in touch with me, please DM me. We'll definitely respond as soon as possible.
Hello, ma'am.
Hello.
Ma'am, did your fellowship at Savita help you more with your work, or would you say it was your own work and your own,
So,
creativity?